Now, let's talk about the management of an important symptom of the lower GI disorders, constipation. And we're not going to be talking about like you are constipated, you need to take laxatives, or how to diagnose constipation. The patient just knows it. I just visit the restroom very infrequently, just once a week or something like that, and the stools are hard or something like that. So we're going to be talking about how are you going to advise your patient when it comes to some important causes of constipation that the patient might not be paying attention to. There is no clear etiology for constipation in vast majority of cases, but in some cases the patient might be taking some medications that could result in this constipation. Calcium channel blockers, as I said, all muscles need calcium to contract. If you're taking calcium channel blocker, your gut is not going to contract, and when your gut does not move, you are going to be constipated. Hypothyroidism. In hypothyroidism, the thyroxine hormone is low. The T3 and T4 are the thyroid hormones are low. So the thyroid hormones, they stimulate all your body cells to metabolize. When you have low thyroid hormones, your intestines will be lazy and you will get constipated. By the same token, immobility, and we see that very frequently in elderly. Immobility in elderly. If you're not walking, you're not going to be defecating. Immobility is one of the important causes of constipation in elderly. And also dehydration. Dehydration, you need to be well hydrated to avoid inspissated stool. So dehydration is going to be a very important contributing factor for constipation. Diabetes. In diabetes, we get kind of numbness to the nerves. Like diabetic patients, why do they get foot ulcers? Because they have numbness. They do not feel it when something goes into the sole of the feet. Because of what? Because of this neuropathy. Well, they have the same neuropathy in their guts, so they do not feel it when the gut is distended. And because they do not feel it, they do not feel the urge to go to the toilet, and this will result in constipation because of the neuropathy seen in diabetics. Iron therapy, a very famous cause of constipation. Narcotic medication use, morphine, of patients who are using opioids for chronic cancer pain. Very important problem in these patients, the constipation. Any drug with anticholinergic side effects. Antihistamines have anticholinergic side effects. Tricyclic antidepressants have anticholinergic side effects. Acetylcholine is important for your gut motility. If you're taking anticholinergic medications, you're going to impair your gut motility. Categories and examples of laxatives, there are so many. We like the bulk-forming laxatives. We like the bulk-forming laxatives like polycarbophil, fibercone, very famous. We also use docosate sodium and docosate calcium. We can use lactulose, which is a sugar, so pay attention to using lactulose in diabetic patients. Magnesium citrate, magnesium hydroxide, the milk of magnesia, very famous laxatives. Bisacodyl and senna, very strong laxatives, very strong stimulant laxatives. And let me give a word of caution here. Never give laxatives, especially the strong ones, the stimulant ones, to any patient with acute abdomen, because this could be some mechanical obstruction that needs surgical intervention. Never give laxatives to a patient who presents with acute abdomen and constipation before surgically exploring this patient to see if there was some mechanical obstruction in this patient. And as I said, the recent laxative which has become very popular in the management of irritable bowel syndrome, lubiprostone or amitiza, which is a chloride channel activator. Let's do the case study of constipation. What do we have in this case? We have a 74-year-old black woman who complains of feeling bloated and constipated for the past month. What's the manifestations of constipation in that patient? Less frequency, longer time to initiate a bowel movement, very hard stools. And let me start with the questions. What are the risk factors contributing to this patient's constipation? This is the most important part of the case study. Well, the age, race, and gender contribute to the constipation, especially the age, of course, the 74-year-old patient. The use of naproxen. What's naproxen? It's a non-steroidal anti-inflammatory for arthritic pain, and this because it is anti-prostaglandin, and prostaglandins might be playing a role in the gut motility. And also she uses aluminum hydroxide for heartburn. Now we have aluminum antacids. Aluminum antacids will result in constipation. Magnesium antacids will result in diarrhea. Aluminum antacids, constipation. Magnesium antacids, diarrhea. This patient has been using aluminum hydroxide. That's why she is constipated. And she gets very little exercise, and this is an important contributing factor. And also she uses caffeine, which is a diuretic. Caffeine has a diuretic effect. Too much coffee, too much urine, this might add to some dehydration. And she's also having poor diet, so a few fresh fruits and few vegetables and whole grains, this will reduce the bulk in her gut, and this adds to the problem of constipation. She's using nifedipine. Nifedipine is what? Calcium channel blocker, again contributing factor to constipation. She's using imipramine, which is an antidepressant, and imipramine is a tricyclic antidepressant with anticholinergic side effects, again contributing to constipation. She's using hydrochlorothiazide, a diuretic, adding to the dehydration status of this patient. And she has high serum calcium concentration and hyperparathyroid disease. All of these are contributing factors to the patient's constipation. What are the clinical signs and symptoms consistent with this patient's constipation? Of course, this is a very easy question, so I'm going to leave it for you to read the manifestations of constipation. It could be decrease in the frequency of defecation and or change in the form of stool, hardening the stool. Why is constipation in this patient not likely the result of irritable bowel syndrome? Why is it not likely the result of irritable bowel syndrome? Because of the following. The patient denied bouts of diarrhea alternating with constipation. It's always constipation. In irritable bowel syndrome, we have diarrhea alternating with constipation. Another thing is the patient denied any abdominal pain or discomfort. And as you remember, irritable bowel syndrome is all about abdominal discomfort. And also the onset of irritable bowel syndrome usually begins in the late teens to early 20s, not in such age.